Good afternoon, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we're joining Dr. Jack West, who's a medical oncologist focusing on thoracic malignancies at City of Hope. He's also the founder and the president of the Global Resource for Advancing Cancer Education and vice president of AccessHope. In our brief discussion today, we're hoping that Dr. West will share his thoughts on few clinically relevant studies that were presented at ASCO and how we can implement these findings in our community practice. Let's welcome Dr. West.
Well, thanks very much. The organization, the nonprofit I'd started is called Global Resource for Advancing Cancer Education, the acronym GRACE. It's really meant to be understandable by everybody. The website's cancergrace.org, and I'd encourage general oncologists, patients, anybody to use it.
Thank you, Dr. West. That website, we were privileged to be introduced by you, and we'll definitely be spreading the word to our patients and other colleagues in community oncology.
Great.
Dr. West, today we'll be focusing on 3 studies, 2 pooled analyses presented by the FDA, and third study focusing on the second-line treatment for non-small cell lung cancer patients. Our goal with this conversation is to give high-level review to our community oncologist and few takeaways from ASCO 2022. Let's jump into the first study.
Thank you, Rohit. So we're looking at the first pooled analysis, which was done for patients with IO alone versus IO and chemo in advanced non-small cell lung cancer patients with high PD-L1. Dr. West, can you please walk us through the study and its findings?
Sure. This was really an exploratory analysis of the pooled results of 12 different studies that had come to the FDA for review that included a subset of patients with PD-L1 of 50% or higher. That constitutes about 28 or 30% of our patients, and they looked at just the various efficacy outcomes for the patients in these studies and whether they correlated with certain clinical features. The box in the red box on the bottom right, that that overall survival was not significantly different, but progression-free survival and response rate were significantly better, favoring the chemoimmunotherapy arm in the recipients of chemoimmunotherapy concurrently compared to IO monotherapy. The results are pretty informative that there is a strong trend toward better survival and a better response rate and progression-free survival for the patients, even with high PD-L1, who were recipients of chemoimmunotherapy up front. These are 2 competing standards. It's not that one is a wrong choice, but we have 2 right choices, but you have to commit to one or the other. What they also saw was that it wasn't exactly the same across the entire spectrum of patients, that patients who were 75 or older did not have this trend of better outcomes with chemoimmunotherapy. The younger patients got more, and the never smoker couldn't be on these trials if you had a known EGFR mutation or ALK rearrangement, but not everyone was tested. And there are other driver mutations where they probably do not benefit as much from immunotherapy. And for various reasons, I would infer that many never smokers have a driver mutation. And these patients did not tend to benefit as much from immunotherapy alone and were far more on the favorable side for chemoimmunotherapy. I think what it says is it's still appropriate to have a shared decision-making process with your patient. There's room for judgment. If you are seeing that they are very symptomatic, have a high tumor burden, and cannot envision that they would do well and still have a good performance status if you started them on immunotherapy and they didn't respond, they might not be candidates for chemo. That's definitely someone where I would strongly favor chemoimmunotherapy. I would err on the side of favoring chemoimmunotherapy. But we also have seen data that, especially with patients who have very high PD-L1, 90 to 100%. Those folks do especially well with immunotherapy alone. We don't want to overtreat folks. So if people have a low tumor burden, they are not that symptomatic and or have high PD-L1, I would still strongly consider immunotherapy alone, because if we're lucky, these patients may do well for years. So I think there's still a role for judgment, but these results add to a sense that if you're going to err on the side of giving the chemo with immunotherapy.
Well, thank you for that summary. I think what you said is important. Shared decision is the key here.
Sure.
We can now move on to the next study.
Continuing with the theme of pooled analysis, the second study we have here looked at first-line treatment for patients with KRAS mutation in non-small cell lung cancer patients. Dr. West, can you please discuss the data and how are you really incorporating this in your practice today?
Well, this is, I think, a pretty simple, shorter story. As I alluded to, we still have questions about which patients with which mutations are better served by targeted therapies or a non-targeted chemo with or without immunotherapy kind of approach. One theme that has emerged in the last few years is that not all driver mutations are the same. Patients with EGFR mutations may benefit from immunotherapy a lot more than we had initially thought or seen. ALK positive patients probably very rarely benefit, those with ROS1 as well. But those who have a KRAS mutation seem to, on first blush, benefit comparably to other patients. But we really haven't had a lot of data to speak to this, and that's where this exploratory analysis by the FDA speaks to these data. So they looked at, again, 12 randomized trials submitted to the FDA for marketing approval. They looked at the patients who had KRAS mutation status. Unfortunately, that's only a pretty limited subset of their total pool had the data available. I believe it was 16%. But as you can see from the curves on the bottom right, each way it really showed the same thing, and that is they track basically the same as KRAS wild type. If anything, the patients with a KRAS mutation may benefit especially from chemoimmunotherapy compared to chemo alone. So what this says, of course, we have sotorasib FDA approved. We got more data this year with adagrasib as another alternative that we may well have available to use. But these have both been studied in previously treated patients. And this leaves us maybe with the niggling question of should we be moving it up front, and maybe we'd be especially inclined to do that if the patients with KRAS mutations didn't benefit from immunotherapy. That's not the case. They appear appropriately treated by the same algorithms we use for non-driver mutation patients or no EGFR or ALK. And so it is, I would say, very appropriate to treat them with Keynote 189, Keynote 407, monotherapy. There's other regimens. There's many choices, but those are all appropriate choices for your patients with a KRAS mutation, and then most likely giving sotorasib subsequently as second-line therapy. So I think this is a pretty clear answer that's not that controversial.
So in your practice, Dr. West, trying to tie these two pool analyses, a patient with KRAS mutation with high PD-L1, would you still favor chemoimmunotherapy in that settings? Let's say their PD-L1 score is 80, 90, 100%, or would you lean more towards IO alone?
Yeah, I think for someone who had a PD-L1 of 90%, that's someone I would really think about monotherapy. I would still use their performance status,
Absolutely.
their total tumor burden. I'm not talking mutational burden, but do they have just pleural studding and they're not that symptomatic? That's a patient where I would not hesitate to favor immunotherapy, because I think this person may do extremely well with pembro alone for years. Yeah, to answer your question, to me, very high PD-L1 does count a fair bit now. All of the data have pointed in the same direction there.
And now, if we had to utilize KRAS inhibitor post-exposure of IO, How would you go about that, or would you be recommending that?
As we're concerned of some increased toxicity that we're starting to see post-IO exposure with KRAS inhibitors, at least with early data.
Yeah, I would probably be inclined to maybe hope for just to put a 6 or 8 weeks in between if you can. I haven't seen enough data on this to really say anything conclusive. I think that we'll likely learn more in the next 6 to 12 months. I would also bear in mind that if someone is really progressing through their first line treatment and has multifocal progression, we know the alternative with the disease is not good, and you have relatively little to lose by doing whatever you can to get control of that cancer.
Absolutely. Well, thank you for that. Now we can jump on to our last study. This is rather a phase 2 study where they looked at a sub-study of LungMap S1800A and use of pembrolizumab and ramucirumab in second-line patients in spite of them progressing on first line, including immunotherapy. Dr. West, this is phase 2. Is this ready for prime time, and what's your take on it?
But I think, as I'm talking about things that were not that controversial at ASCO, this is, to me, the most controversial question. You boiled it down right there, that it's a positive trial. I would definitely give credit to SWOG for the LungMap trial in general, because it has become a very successful platform for testing many questions in previously treated advanced non-small cell. Literally thousands of patients have been screened. Many different trials have been asked, many publications, many of them, most of them negative, but a negative answer to a question is still valuable contribution to the science. And okay, asked and answered, we can move on to the next one. And it's been a very efficient platform for that. What I would say is that this was a positive trial, and it looked encouraging for overall survival. Interestingly, we didn't see differences in response rate or progression-free survival in this comparison of pembro ramucirumab versus standard of care. I like also that the standard of care was a dealer's choice, and I also especially like that so many of the patients got docetaxel ramucirumab, which I think is by a small margin the best option that we have. I think using docetaxel alone is a little suboptimal when we have data that the best survival is with docetaxel ramucirumab. The discussant noted that this was potentially practice changing. That's where I disagree. I think these results are very provocative. They're positive, but it's a randomized phase 2 trial. And what it should be doing is saying this merits being looked at in a phase 3 study, larger format. This was still just a little over 130 patients in total. And there's a lot of variability. We all know, those of us who've treated so many of these patients, a lot of variability in how patients have actually done on immunotherapy. Some may still be benefiting substantially from the immunotherapy. Some went through it pretty quickly. And so with small cohorts of a few dozen patients on each arm, I think that's just a too small a sample to make this standard practice. And especially, I would say, when gemcitabine is a significant minority of what patients got. And we've tested that and have clarified that's not an effective therapy. So I'm all for this being tested, which it is being done in a phase 3. That is great. And if it recapitulates this, it should change practice. But I would say that we should not change practice based on the phase 2.
No, couldn't agree more. Well, thank you so much. We truly appreciate your time, Dr. West. We hope that this brief discussion would spark an interest in our community oncologists to dig a little deeper in each of these studies. Thank you so much again for your time.
My pleasure. Great talking to you.